Good morning, everyone, and welcome to today's COHTAC Share and Learn titled Tackling Tobacco to Advance Oral Health. My name is Aubrey Kotick, and I'm part of the California Oral Health Technical Assistance Center, and we're thrilled to have you all here today. I'm going to go ahead and advance the slides and get us going. So a couple of housekeeping items. So first is that today's meeting is being recorded and will be posted to the COHTAC website and our YouTube channel. And this will also be sent out to all of you following today. Links to the recording, slides, any resources that are shared will all be sent to you. If you have comments or questions, please put them in the meeting chat box. We'll be keeping track of all questions there, and we'll have some time towards the end to have a robust discussion and answer all of your questions. And then we'll also do a little evaluation survey at the end. It's both a poll and a survey where you can give us comments. And we really appreciate your feedback and hope that you take a couple of minutes to provide that to us. Okay, so on to what we're all here today for. So we're excited to invite the local lead agencies in tobacco cessation today. COHTAC is really funded to support local oral health programs. So those are the LHJs implementing oral health objectives locally. But with the topic of today, we've invited all of the local tobacco folks to be joining. So we're thrilled to have you all here. And I'm going to run through our agenda and introduce our speakers. So we'll start with an overview of the two programs that are here today, local oral health programs, or LOHPs as we call them, by way of the Office of Oral Health, and local lead agencies in tobacco prevention, otherwise known as LLAs, by way of the California Tobacco Prevention Program, or CTPP. So Rachel Kolarafi, a program consultant with CTPP, yep, will kick us off by sharing more about CTPP, and then we'll move to Dr. Benjamin Chaffee, who's a professor in the Division of Oral Epidemiology and Dental Public Health at the UCSF School of Dentistry, and the director of the Global Oral Health Program, who will go more into the effects of tobacco use and other products on oral health. And then Liz Couch, an assistant adjunct professor and project policy analyst at the UCSF School of Dentistry, will share evidence-based approaches to tobacco cessation and how all healthcare providers, and especially dental providers, can get more involved. And like I said, we'll end with lots of time to answer your questions and consider how the two programs here today can collaborate and really amplify the work that you're doing together. I did brief introductions of our speakers, but I'm going to put a link in the chat that has a lot more detailed information about how wonderful all of them are. Here we go. Okay. So I wanted to set the stage a little bit just with context and who's here today. So the LLAs, which are here in green at the end, again, are funded through the California Tobacco Prevention Program. And the LOHPs, the local oral health programs, are funded through the Office of Oral Health, but you're all through CDPH and especially through the Center for Healthy Communities. So I just want to highlight that these are the two programs that are here today that we're trying to find ways to increase collaboration. There are some intersecting objectives. So a potential LLA cessation activity really emphasizes collaborating with different programs like oral health to integrate what you're doing locally. And for LOHPs, there's a specific work plan objective, that's number 4, that has a lot of different tobacco cessation activities under there. So this is just to show how, this is a start of the conversation, or maybe you're already collaborating, but we're hoping to find ways for you to collaborate more. And we'll talk more about this toward the end of the presentation. So I'm going to stop there and then invite Rachel to kick us off.
All right, thank you so much, Aubrey. Just making sure everything looks good on your screen. Awesome. Thank you all so much for having me today. I really am honored and privileged to be part of some of the folks that are going to be presenting to you all today. Really impressive folks that just know a lot on here. So really great to just start us off. As Aubrey has mentioned, I am a program consultant over at the California Tobacco Prevention Program. And specifically, I serve on a lot of projects that oversee cessation services and resources. So really happy to share that with you all today. Some of our local partners and folks that may be on this call are familiar with some of the both over program overview and also resources that I'll be sharing for you all today. But when I was talking to COHTAC about what might be best, we really wanted to provide just a general foundation and an opportunity for folks to really understand where potential networking and collaboration opportunities could intersect, as well as just provide an overview because as many of all know, there's so many resources that are offered, but are ever ongoing and always updating. So I just really want to make sure that everyone has the foundation and understanding of what's the most current and up to date. Okay. So first, I'm going to start off with just a general CTP overview. And this is to give everyone a foundation of understanding of how we specifically at CTPP encourage and really emphasize cessation protocols, as well as just other initiatives and objectives into the work that we do, and ask that our projects who are funded do. So we're really a comprehensive program here at CTPP. And what that means is that the tobacco industry, as you all know, is really multidimensional and always innovating and returning to themes that we've worked on in the past. So what we do in order to be really effectively countering them is to have a multidimensional approach to that. And so our program needs to be focused on all things at all the time and really making sure that we keep the conversation about tobacco prevention always on forward going. So with that, for the California intervention aspect that we all do, in brief, our program has very been successful in pairing both the media with community engagement, and which then results in changes of what is normal in our communities in respect to tobacco use and tobacco sales. So what we try to really embody is changing that social norm of what's in the communities itself. And we do so through what we call our social norm strategy. And this is really foundational to a lot of ways of how we approach our objectives and other aspects of what we try to provide resources and services on. So in order to do that, we create an environment where tobacco use is less desirable, less accessible, and less accessible. And this then thus leads to lasting changes, especially in younger generations regarding tobacco use that can then only be secured by changing the world in which they grow up in. So we really try to make sure that a lot of what we do in terms of both our objectives and activity language is always going back to this idea of social norm change. So really just touching further on just changing social norm is not a stagnant initiative, and we want to really make sure that that is clear and emphasized. You have to keep it always continuing and pull people into the program. You might notice that for LLAs who have their scope of work activities, they're designed to help move along this cycle. So that is raising awareness or concerns such as community education approaches, increased social concerns such as policy education, coalition building, letters of support, legislation such as policy initiatives, and implementation such as the expectation and the contentment of what that means. So just really making sure to make it clear that it's just an ongoing cycle. We're very aware of that and really wanting to just in order to change social norm, we have to also keep changing and evolving ourselves. So the goal in general for the California Tobacco Prevention Program is social norm change, and then the outcome then leads to then prevention and cessation. So this is different than some other public health programs, and so often the focus can sometimes be on education and prevention. and sensation and hope that things will change. But our program really wanted to make sure that making the change and utilizing measurements of prevention and sensation to help elevate our success at both the local level as well as just overall in California as a whole. So that's really the way that we approach it with our objectives. And then next, why policy change is so important in terms of the objectives that we do at CTPP. So one, it creates demand and reinforces change for individual and group behavior. It protects health or the environment in general for the communities that we serve and both live in. It sets expectations. It maximizes resources. It builds the capacity of local communities and institutionalizes change, like we said. So, in general, just really wanted to give some overview of especially how we approach in terms of sensation at CTPP, because it's a bit different of approach than some might think, especially since we're not going right into that education as that first measure. And then the last just overview slide that I wanted to cover for our time together in terms of just focusing on overview of CTPP is really showcasing kind of how that all comes together. So we like to call this our garden slide at CTPP. It's to really emphasize and showcase who all of our different parties that come into play and really help make this change, especially for sensation efforts. So as you can see, by this lovely key here. Coalitions are the grass that brings it all together. Media, like I talked about earlier, that drives forces is utilized with the rain here that flourishes all the garden. The competitive grants are the flowers that you see pollinated here by our lovely state projects, which are the insects. An example of a statewide project would be like Kick It California, that I'll be talking about momentarily. Health departments are this lovely bridge that bring it all together. Evaluation is the sun that brings all of the garden to its full potential. And then also the trees are emphasizing monies and funding source grants. So with all that covered for background of just general of just how CTP is as an organization and then how sensation plays into that, I'm going to now touch into the majority of my presentation, which is sensation resources and services. So these are services and resources that have been created by CTP themselves, or also just services that we also fund through our grants. So before I do, just emphasizing kind of what will be, I think, echoed and talked about throughout today's conversation by myself and other presenters. But beyond tobacco prevention, cessation is the ultimate goal to stop or minimize adverse health effects of tobacco use. It's also a successful measure of tobacco prevention programs, policy, and initiatives. And I think that's really echoed in a lot of your scope of work objectives or initiatives that you all are doing. And then just noting that although California has the third lowest smoking rate in the nation, um, we just want to emphasize with just its high population, that still means that millions of Californians are still smoking or using tobacco products. So we really just want to make sure that when we're talking about creating social norm change, that sensation is part of that conversation. So firstly, I'll just touch briefly on sensation resource flyers that I've created with some of our amazing partners. So these provide quit support tips and recommendations specifically to young people using vapes or other tobacco products. These are some screenshots of them on the right-hand side here, as well as providing a compare list of existing sensation resources, as you can potentially see here in the text. So I've provided some hyperlinks throughout my presentation. I know that they'll be shared after with you all, but really wanted to provide quick access if you wanted to use those. And noting that these are also resource flyers that are downloadable in English, Spanish, traditional Chinese, and simplified Chinese. Next, I'm going to be talking about, I believe, a program and service that many folks on this call may be familiar with, but really wanted to emphasize, especially when talking to health oral professionals, how these resources at Kick It California and Services can really help their clients or just other folks in your community when talking about sensation services regarding oral health. So, just a quick overview of Kick It California. This program is 32 years old and operating out of UC San Diego. It's helped over 1 million Californians to date. It provides one-on-one coaching validated in multiple randomized controlled trials. So it's been tried and true tested, specialized protocol to help people quit smoking, smokeless tobacco, and oral nicotine pouches. So really keeping in mind that Kick It California very much stays up to date with especially a lot of like the latest trends that we see in tobacco use products. And also noting that they provide services in English, Spanish, Mandarin, Cantonese, Korean, Vietnamese, and are opened many hours during the week. Specifically, this is a great screen to just showcase an overview of all the services and resources that are provided through Kickit. So a lot of you or a lot of your clients or community members may just be familiar with just their phone line service. But again, when providing this foundation overview of what we have here for all you today, really want to emphasize that there's more to Kickit than just that. There's their chat services online. There's a texting program. There's free downloadable material flyers that you all especially can provide to your community members and oral health partners and health professionals. There's a brand new app, which I'll be going over shortly. There's eight quit videos that are really popular both in English and Spanish that are great, especially to showcase sensation services. And most recently, there's also now availability of free NRT patches, so nicotine replacement therapy patches for eligibility applies. So just noting that there is still eligibility restrictions, but noting also how this is a huge win. We've been really working with Kick It California for a long time to make sure that this can be something that we're potentially able to provide to our clients that are eligible. So just noting that for you all as well. Specifically, the app that I mentioned, it's brand new. It came out earlier this year, and I'm really so excited about it because it provides really updated and easy ways, especially if you all are connecting with a health professional that wants to defer to self-referral or other aspects for an individual to take the initiative for themselves. This is a great tool, especially because it provides daily check-ins, tracking progress, building a quit plan on their own time, and then it has some other aspects to keep them engaged. And noting that this app is in a one-stop shop, so it has both support for smoking and vaping. Previously, there were two separate apps that were one for smoking, one for vaping, but really understanding that there's dual usage. So really, congratulations to Kickit for trying to get all that packed into just one app. And so it's still evolving and ever on growing, but really excited for this new resource for you all to share with your community. Um, Before I get into more specifics about oral health, again, just for background information, just noting for especially folks that may not be familiar or folks that you all connect with in your community, really want to making sure that we talk about Kickit's record in terms of serving priority populations. Like we said, in terms of randomized control trials, Kickit has been very much testing over their many years of service of how extensively they are able to reach throughout the community and various communities at that. So compared to English-speaking Cantonese ethnic groups, noting that African Americans that smoke are more likely to use the quit line, American Indians that smoke are equally likely to use the quit line. Asian immigrants who prefer to speak Chinese, Vietnamese, and Korean that smoke are equally likely to use the quit line. And then we also go into some other aspects. So the LGBTQ plus individuals that smoke are also equally likely to use the quit line as non-LGBTQ plus individuals that smoke. Low-income individuals that smoke are actively using the quitline services and noting that over 70% of its current clients are Medicaid recipients. So that's a huge majority of folks that utilize their services. For behavioral health, noting that over 50% of the quitline clients report having at least one mental health condition. And for the rural population, noting that it's just as likely, if not more, that they use the quitline services as the urban population. So just emphasizing that and wanting to make sure that that is all clear when you connect with your communities as well for folks talking about how maybe the service doesn't apply to them, just noting that it is actively reaching out to these communities and individuals, especially folks when regarding sensation services that may be most adaptable and approachable for them. So specifically going into resources for oral health providers, this is going to be covered by a couple of the other presenters. So I'm going to go through this fairly quickly, but noting again, Kick really wanted to make sure that I provided a lot of lovely hyperlinks for you all and other things that will be shared, I'm sure, afterwards in this PowerPoint presentation. So smoking and other tobacco use can cause, as you all know, oral health problems such as oral cancer, gum disease, tooth loss, tooth staining, and bad breath. And quitting is one of the best things that their patient can do for their oral health. So how quitting tobacco and nicotine can improve for your patients when just giving maybe an overview list or a quick bullet point list. Folks can note mouth sores from using tobacco health will heal in within 2 weeks, lower risk of uh, uh, Lee, placa. I'm sure that that's not correct. My apologies. And then also reduced tooth decay, cavities, receding gum lines, black hairy tongue, bad breath, and tea staining, as well as decrease mouth and throat cancer. And then specifically, just noting how Kick It can help in terms of oral health providers. So, tobacco nicotine cessation is one of the most effective strategies to improve oral health in Californians and can be reached by increasing the percentages of patients who actually receive and are referred to evidence-based tobacco cessation counseling and other cessation aids in dental care settings. However, noting that dental health professionals may not always have time to provide these sensation services because we know that that's a common thing noted. There's not enough time. So that's just especially where you can highlight how Kick It California comes in. So specifically, this is going to, again, be covered by, I believe, some other presenters, but Ask, Advise, Refer is going to be a great way for you all then to connect with your partners, especially when referring to about proactive referrals. So people are more likely to get Kick It Quit coaching when referred to by their healthcare provider, and that includes oral health professionals. So Kick It California can offer options for those providers to securely refer both their patients and clients to these proven science-based quit services. So it could either be through proactive referral, where the health professional takes that initial step, or it can be through self-referral, where that patient themselves are the one taking an initial step. And this can be done through either web-based referrals, electronic referrals, or if it's self-based referral, potentially through a printed material flyer handout that Kick It is noting that there's free printing options for you all to download. So reason that you all might want to, though, suggest in terms of what type of referral would be best is proactive referral reasonings include associated with a significant higher participation rate than just simple advice to quit. So instead of a health professional just saying, oh, you really should quit, and they're most likely going to say, yeah, I know. This can be increased from 2 to 3% just alone by just saying you should quit to 40%. So significantly higher participation in attempting to quit rates. Sending an e-referral through the electronic medical records can help help organizations meet various metrics, such as their QIP. So that's something that you can all recommend to health professionals if that is a potential option that might entice them to do so. Clinical teams can also make a big impact on the lives of their patients and reduce healthcare costs by referring them to evidence-based treatment programs. So again, thinking about the benefits that go further down the line. So this is for you all to refer to for later, especially when thinking about when someone asks, well, what happens when a proactive referral is taken part in? This is especially what you all can then let them know of what the process is. So also noting here, when referring a patient, this can be 13 years old or higher. So sometimes there's an assumption that the Kick It California services are only for adults, but noting that that's not the case. And again, in some cases, we wish this could be lower, which is current trends of use, but noting that a health professional may not be aware that this can be a great resource for youth and young adults as well. So just noting it can refer patients who want help quitting smoking or using smokeless tobacco. A quick coach will then call the patient after that referral is done within 2 to 5 business days once the referral is made and create a personalized quit plan and set a quit date. After the initial coaching call and relapse sensitive follow-up calls are scheduled. And then just noting that the patients will receive then education about withdrawal symptoms, pharmacotherapy, and referral to other services if appropriate. So there's a lot of initial steps that go into when someone is referred. It's not just one phone call, it's an active process throughout of when a quick coach makes a plan and how that approach is done with each person. It's very individualized. And again, these are for quick link purposes for web-based referrals on my left, and then the e-referral, so electronic health record on the right. And there's some great other emails or contact information if folks are in need of assistance as well. And then these are the printouts that were mentioned earlier in terms of which one that could be used for a self referral as well. But there's many other free downloadable service flyers and service printouts for you all to look at as well in the links. And then lastly, just noting for just additional free education and training materials that might be of all interest to you all, or it could also be for health professionals as well. Kick It provides basic education and training materials on tobacco and nicotine cessation topics through their catalog, website training links, and their specific tobacco and cessation health related classes. Additionally, I would be remiss not to also mention that we CTPP also fund UCSF Smoking Cessation Leadership Center, the center's California Center for Tobacco Cessation, which is a statewide program that also provides cessation training and technical assistance services on tobacco and nicotine cessation and prevention partners, and they have an amazing catalog of also free education and training materials. Noting that specifically, I linked the one down below as well that might be of interest to you all of one of their recent webinars that happened earlier this year called Empowering Change Using Brief Motivational Interviewing for Tobacco Cessation and Oral Cancer Prevention webinar. And that was also co-hosted by the American Dental Hygienists Association. So a great webinar for folks to check out for the recording. And then quickly just overviewing that there's a lot of county enrollment data reports for you all to look at from your perspective of seeing who is enrolling in Kick It. And this can be, again, done through part by looking at both demographics, behavioral health conditions, physical health conditions, and many others. And noting that these reports are both monthly and 6-month reports that people enroll in their program and how they engage with their services. So really encourage folks to look at that if you want a deeper dive specifically for your area and the populations in which you serve in your jurisdictions. And lastly, county contact information. So this will be covered by folks later on, but in terms of local health services and office offering link websites, you can both do this both through Kick It California's website as well as CDPH's website at CTPP. And we just want to recognize that because California is so large and has such diverse populations across the vast area, we highly encourage you all to contact like a local health service department that you all are familiar with or maybe part of yourself for more information. But since this is such a great opportunity for cross collaboration, I would hate to not emphasize that as well for you all to connect with folks in your area. And then just lastly, here is contact information that you all can use later. And that is the end of my slides. Thank you all so much.
Amazing. Thank you, Rachel. That was wonderful. And if you have questions for Rachel, please drop them in the chat and we'll get to those toward the end of the presentation. But now I'd like to pass it off to Dr. Ben Chaffee.
Yeah, thank you so much. Thanks for the opportunity to present today. I'm glad to see so many people joining us. My name is Ben Chaffee. I'm from the University of California, San Francisco, and I'll be sharing a bit today about how tobacco products, both conventional products, smoking cigarettes, and new and emerging products impact oral health and the implications of that for dental patients and dental practice. No conflicts of interest to disclose. My team and I are grateful for the support we've received from the California Department of Public Health and the National Institutes of Health. And when I give a talk like this, I often need to remind the audience, perhaps less so this audience, that tobacco use is still a big deal. That in this century, the 21st century, we're expected to see somewhere in the neighborhood of 1 billion deaths from the use of tobacco. That's 9 million preventable deaths per year happening right now, including hundreds of thousands of those in the United States and tens of thousands of those right here in California. This remains an urgent issue. And as we've seen, it's not just an issue of smoking cigarettes. While cigarettes are still by far the most consumed tobacco product, we've seen the emergence of electronic cigarettes and new oral tobacco products like nicotine pouches. And this creates real challenges, real questions for researchers, for policymakers, for clinicians, and also for public health professionals, what to do and what to message around these new and emerging products. And for our dental professionals, there is no question that tobacco use causes poor oral health. Tobacco use causes the diseases that dentists are tasked with treating, whether we're talking about gum disease, loss of teeth, cancer of the oral cavity, or a host of other conditions. In addition, tobacco use, particularly cigarette smoking, makes the treatments that dental professionals have to deal with these diseases less effective, more likely to find that dental implants will fail in a patient who smokes, for instance. And we really want to stress that dentists, dental hygienists, other members of the dental team are well positioned to do something about that. That the skills and patient communications and access to patients on a regular basis, as well as the resources with which dental professionals can connect their patients, are tremendous. We really can make a difference. All that we need to do is reach out and try. So I'll give an overview quickly of the implications of tobacco use for health overall and oral health in particular. Starting by remembering that the combustible cigarette, as familiar as it is to all of us, and while it doesn't look like much, this is a carefully designed device with a lot of science and research behind it to do one thing, and that's maximize addiction. It is still the most commonly used tobacco product by adults in the United States, around 11% or so prevalence of use. And while we are doing much better comparatively in California, we also need to remember that we have marked disparities in use of these products and diseases caused by them, whether we define the differences by geography, socioeconomic position, or by demographic characteristics. And cigarette smoke does not spare any part of the body. It causes damage every place it goes, including in people who smoke cigarettes and those exposed to the smoke just by being nearby cigarettes. Deaths caused by cigarette smoking are approximately evenly divided between cancer, non-cancer disease of the lungs, and cardiovascular disease. But smoking also causes all these other very serious diseases and conditions that damage quality of life and contribute to mortality. And so even if cigarette smoking did nothing to the oral cavity, it would still be imperative in our mind that dental professionals and all health professionals get involved in helping our patients to quit use of tobacco, not start tobacco, and live healthier lives. Going back specifically to oral health, we know that smoking tobacco causes cancer of the oral cavity, causes gum disease, disease of all the tissues around the teeth that hold the teeth in place, contributes to tooth loss, failure of dental implants, and failure of other treatments like surgeries that may occur in the dental practice, oral leukoplakia, white patches and lesions in the mouth, calculus, plaque, staining, bad breath, and perhaps with less conclusive evidence may also play a role in tooth decay, dry mouth, and oral pain. Pretty much anything a dental professional would have to deal with. And so how does tobacco smoke do this? Well, one, quite obvious for cancer, tobacco smoke is known to contain dozens of different well-characterized cancer-causing chemicals known to cause cancer in humans. But specifically for gum disease, one, the presence of smoke changes the bacteria, the bugs, the microbes that live in the mouth and shift them towards a more disease-causing profile. Tobacco smoke also makes the body's own defenses, own immune system, less effective at responding to those bacteria that live in the mouth. Also, tobacco impairs the ability of the body to heal and repair after there's an insult, and so to recover from gum disease, and reduces blood flow. Blood flow is essential for keeping oral tissues healthy. It's not just nicotine constricting blood vessels. You'll actually see in a long-term tobacco user, there are fewer blood vessels overall throughout the gums and those tissues that keep the mouth healthy. Damage caused by tobacco is not limited to cigarettes, of course. Cigars, while highly variable in the size that they come in, the way that they're used, but many cigars, and perhaps the most consumed cigars overall, are these small cigars and cigarillos that really only differ from cigarettes in name only. The research supporting the oral health effects of cigars is sparse compared to the evidence looking at cigarettes, but we have good reason to believe, extrapolating and what we have studied on cigars specifically, that the oral health effects would be quite similar to those from smoking cigarettes. Non-smoked oral products also harm oral health. We think about conventional smokeless products like moist snuff and chewing tobacco. These are associated with cancer of the oral cavity. They're also associated with cancer elsewhere in the body, such as cancer of the pancreas, and they're associated with tooth loss. For our patients, unfortunately, we have fewer proven cessation tools on which to rely when it comes to quitting smokeless tobacco use than we have for cigarettes, although there are resources available. And remember, too, these products are not that different from smoked tobacco. In fact, the largest brands in this country are all owned by the largest multinational cigarette companies. And oral tobacco looks a lot different than it did just 5 to 10 years ago. We've seen rapid emergence of nicotine pouches, these Zyn being a market leader, as well as nicotine-infused toothpicks, gums, gummies, and lozenges that are carving out a new place in the market. And these nicotine pouches in particular, these look like little tea bags. They often come in these round canisters. They contain nicotine as well as other fillers and flavors, and they're marketed as a way to get nicotine satisfaction and marketed very explicitly with language that says tobacco-free, despite the fact that the nicotine in them, in most cases, is derived from a tobacco plant. But that messaging has been very effective, and interest in these products has grown outside the traditional oral tobacco market. So particularly thinking about women and people who otherwise wouldn't use tobacco and do not smoke. So this has raised a lot of questions. What are the health risks specifically of nicotine pouches, and what should our response be to them? A lot of these questions remain unanswered. I think for me, while the evidence is still accumulating, I don't think we have to wait to have reason for concern. Use right now among adolescents under age 18 is still relatively low. Although sales data and online attention suggests that it is quite plausible that use could increase quite soon. And nicotine in and of itself is not harm-free. Nicotine is clearly highly addictive, and addiction is a serious substance use disorder, particularly among young people who may see their brain development changed by exposure to nicotine. We don't have any evidence to suggest that these products help smokers to quit, and in fact, exposure to more nicotine may make quitting cigarette smoking harder. And remember that the companies that bring you these products also make cigarettes. If they were truly going to reduce cigarette smoking, you wouldn't see companies that profit from cigarettes selling them so aggressively. And these products remind me, of course, of electronic cigarettes that preceded pouches to the market by 5 to 10 years. Electronic cigarettes are much more familiar with us now that they've been around for some time, but as a reminder, they are battery-powered devices, and the job is to put nicotine into an aerosol up into the air that can be breathed in by the user. Most use of e-cigarettes is among adult cigarette smokers, and unfortunately, among children and teenagers. They do deliver some really noxious chemicals, some of the same toxins you can find in cigarette smoke, although they do so at much lower levels than cigarettes. And their design has changed a lot. 10, 15 years ago, they looked like these little cigarettes, like you'd see in that ad with the purple background. And we know today they're found in a wide variety of sizes and shapes and colors, like you can see on this slide here. They go by a lot of different names: vape pens, sometimes brand names like Juul and Puff bars, or more formally, electronic nicotine delivery systems. And as their design has evolved, some of the most popular products now look like these very round and sleek, playful, colorful devices, including devices with video game consoles built right into the back of them. Generally, over time, these products have become easier to use, more accessible, and more effective, more addictive in delivering nicotine. Use of these products is not as widespread as cigarettes. Nationally, maybe 4 to 5% of adults are using those. And most vaping is happening among young adults in that 18 to 24 age range. And most vaping is happening in concert with cigarette smoking, at least among adults. For youth, adolescents up to age 18, this has been the most used tobacco product for the last decade. We saw peak national use of these devices reaching unfathomable levels of close to 30% of high school students. That number, fortunately, has been coming down, but I still believe it's an issue of concern. We've got work yet to do. So the aerosol in e-cigarettes, the vape smoke, so to speak, does contain some pretty noxious stuff. Acetaldehyde, formaldehyde, toluene, these are known carcinogens, as well as heavy metals like lead. Some of the same stuff you'd find in cigarettes, albeit, like I said, at much lower levels. And so if you take a cigarette smoker in a controlled environment and they switch over to only use electronic cigarettes, over time, you would see less exposure in their body to some of these harmful chemicals. And so for those who are proponents of an idea called harm reduction, this is the promise of electronic cigarettes, that for smokers who are unable or unwilling to quit nicotine for whatever reason, this could be a cleaner, quote unquote, source of nicotine that could actually save lives quickly. This has been a position embraced by the United Kingdom's health agencies, for instance, much less so here in the United States and certainly in California. But in the UK, the government was actually giving away free electronic cigarettes as smoking cessation devices. What could possibly go wrong with a policy like that? Is a position also embraced by the industry. They have marketed themselves as finding a solution to the problem of smoking, not mentioning it as a problem caused by their companies themselves. But they see this as a way to improve their image and perhaps get a more favorable perception of themselves among the public and among regulators. The problems for me and for others with a harm reduction position is that as currently marketed and regulated, adult smokers are not switching over to e-cigarettes in large appreciable numbers. Most adult e-cigarette users are also smoking. There are dual users of both products and continue to be addicted to nicotine, which may make quitting harder. We'd seen great success in tobacco control prior to any sort of disruption by vaping, and there stands to be perhaps a slowing of that progress. Of course, concerned about youth, concerned about being able to trust the companies that make these products, and that this reduction in harm, while you may see a reduction in certain toxic chemicals, how much actual health is spared may not match initially optimistic expectations. In fact, as more evidence has accumulated, electronic cigarettes themselves may have serious risks to the cardiovascular system by impairing the way that blood vessels function. They may have respiratory risks, at least as exemplified in epidemiologic studies that see higher self-reported symptoms of things like cough and bronchitis among electronic cigarette users. Some evidence to suggest changes at the cellular level, damage in DNA. Whenever you hear damage to DNA that perks up ears, you should be concerned about carcinogenic processes. Although I need to be clear, we don't yet have hard evidence to show that electronic cigarettes cause cancer. And in terms of quitting smoking, it is true. Some adults will say that electronic cigarettes have helped them to quit. But remember that electronic cigarettes have not been approved or authorized by any government agency as a cessation device. In fact, no electronic cigarette company has sought to have their devices designated in that way. There are randomized controlled trials that suggest electronic cigarettes could be used in this way and could be effective, similarly effective to existing cessation aids like nicotine replacement therapy. But what happens in a trial doesn't always match what we're seeing in the real world, which is really high levels of dual use among those who try to use electronic cigarettes to quit. So for me, if a dental patient comes in and says, look, I'm interested in trying vaping as a way to quit, we say priority number one is, I'm so glad to hear that you're interested in making a quit attempt. That is not easy for a patient to reach that point, and we should support that willingness. And of course, we should be then ready to connect that patient with evidence-based and approved cessation aids. But don't let concerns about e-cigarette somehow scuttle or talk that patient out of making a quit attempt. So what could e-cigarettes specifically do to oral health? Well, they could explode in the patient's face. These are injuries caused by exploding electronic cigarettes. This right here, this radio opacity, that is not a cervical vertebrae. That is an e-cigarette cartridge that flew in the back of somebody's mouth following an explosion. I'll say while dental professionals could see this in their practice, you'll notice the date on some of these images. In the last 7 to 8 years or so, the quality control over manufacturing these products has gotten better. I'm really not as concerned about explosions of electronic cigarettes, but in terms of hard evidence of oral health harms, it's difficult to build an evidence base. One, many of the oral diseases that could be caused by nicotine and tobacco products develop over decades of time, and e-cigarettes haven't been around all that long. Most people who use them are younger, and therefore not really our risk group for tooth loss and gum disease. And most adults who do vape and use electronic cigarettes have a history of also smoking cigarettes. So untangling what caused what is very difficult to do. It's tough to do these studies in the lab and equate those laboratory studies to humans. And still, fortunately, the prevalence of these products, the prevalence of use is relatively small, which makes it harder to detect the diseases they may cause. But we do have some evidence. Vaping may change the microbiome, the bugs, the bacteria that live in the mouth. In fact, good evidence that it is changed with exposure to vaping. It's a profile that looks different than what you'd see in the mouth of a non-nicotine, non-tobacco user, and different from what you'd see in somebody who smokes cigarettes. Some of these differences may be associated with bugs and bacteria that lead to periodontal disease, but exactly the links of how severe that disease may be still need to be uncovered. Studies in actual clinical patients suggest possible links with gum bleeding, with inflammation around implants, with lesions in the mouth, although these studies have a lot of limitations. Many of these were done in small sample sizes, may be complicated by patients with a past history of smoking, and a lot of the conditions we really care about, as I said earlier, may take many years to develop. So, my team and others, we spent a lot of time looking at large population-based studies done with epidemiologic methods. And sure enough, these studies have shown associations between using electronic cigarettes and common oral health outcomes like bleeding gums, periodontal disease, mouth and throat irritation. Challenges with these types of studies are that the associations we see between oral health and vaping are weaker than the associations we see between oral health and tobacco smoking. And a lot of times these studies, the oral health outcomes are by self-report on behalf of the patient, as opposed to actual clinical examinations, which can make pulling out the real associations a little bit harder to do. And again, I would say dental professionals should care about tobacco, even if it doesn't cause oral health, even if it didn't cause oral health problems, and it does, and should care about vaping, regardless of what the evidence tells us specifically to oral health. And a lot of it is because of our concerns about effectiveness for tobacco, for smoking cessation, these changes that may affect the oral cavity, harms to other parts of the body, including the heart and the lungs, and uptake by youth, the potential that this could renormalize nicotine use as something that is common and accepted in society. Our dental professionals have a strong voice. They're influential and trusted. Their professional organizations are well respected. And I strongly should be encouraging our dental professionals to use that influence and leverage it to advance policy that protects the public. In the time I have left, I want to say a few things about cannabis and how it may be important for dental professionals. We know that cannabis has evolved both in how the product is used and how the public perceives it. For many decades, cannabis was perceived as a drug, a dangerous drug, something for only degenerates would use. Today, cannabis is good for you. It is a health and wellness product for you, for your pet. This is an actual ad for CBD oil for your doggy. And the point is, regardless of what the possible health benefits or harms of what cannabis may be, access has never been easier and social acceptance has never been higher than at any point in the last 50 years. And use is going up as well. Cannabis does have some serious health effects. Is psychoactive, can cause distorted perception and lack of concentration. At very high concentrations of cannabis can cause sedate individuals, cause respiratory depression, which can be serious, hyperemesis, very severe vomiting, and cardiovascular effects. Increases the risk of motor vehicle accidents, and for young people who use may harm the development of their brains. Cannabis use is not addictive in the same way that nicotine is chemically, but somewhere in the neighborhood of 1 out of 10 users of cannabis will develop use disorder and some form of dependence or experience withdrawal upon trying to quit. Specifically for oral health, pretty strong evidence that cannabis will cause dry mouth, fairly convincing evidence that it is linked with gum disease. Other outcomes, I have question marks here. I think the research needs to catch up a bit and close some gaps, but are there potential for really important oral health harms? And a lot of that comes from smoked cannabis, smoked marijuana, because that smoke profile looks a whole lot like the profile of cigarette smoke. For dental practice, recognize that many patients use these products. And if a patient comes into the practice, comes in for a dental appointment under the influence, that patient may be more anxious, agitated, may not be able to make good decisions when it comes to their health, and there may be potentially dangerous interactions with drugs that a dentist or dental professional may be using during that appointment or prescribing. So my recommendations for dental professionals when it comes to cannabis is at the very least talk about it. Include it in your conversations with patients. Ask if your patients are using these products and document it in the patient history. Recognizing that some patients may choose to self-medicate with cannabis products as a way to deal with dental conditions, whether it's oral pain or anxiety around a dental appointment. Recognizing that if a patient arrives at a dental appointment under the influence or intoxicated, it is no longer safe to treat that patient. And having a policy or protocol in place in your office and an expectation with those patients that if they arrive under the influence, they will be sent home and be reappointed for a time that they can be treated safely. And finally, I would recommend too that recognize in our post-operative instructions, you say you come in, you have a tooth extracted, your dentist is going to tell you, okay, take care of that wound site, don't drink through a straw, don't smoke. Don't smoke means don't smoke anything, not just cigarettes. Don't smoke cigars. Don't smoke weed that can harm your oral cavity while it's trying to heal. And a few last thoughts before I pass it over to my colleague, Liz Couch, is just remembering that this global pandemic of death and destruction caused by tobacco is caused by one thing: an industry that makes money from selling a product that kills its customers. Their promotion and normalization of these products is what is causing the death and destruction that our tobacco control efforts are combating on a daily basis. And if we, as public health professionals, certainly want to be part of this tobacco endgame, and if we want to recruit our health professionals, including the dental sphere, to join this fight, it's part of it begins with addressing tobacco use, talking about it with all patients at every visit, and at a minimum, committing to these brief interventions as a part of routine care. Asking increasing levels of motivation so our patients are closer to the ability to accept a quit attempt, to be willing to make that jump, and then connecting those patients who make that commitment with real evidence supported resources to get there. And as I said earlier, using your position as a trusted profession to advance policies that can bring the tobacco epidemic to an end. I'll stop there. Thanks for your attention. I saw a lot of comments in the chat. I'll try to jump in and type on those as we move to the next presentation. Thank you.
Amazing. Thank you, Ben. So lovely to have you here, and passing it off to Liz. We don't hear
Great.
you, Liz. Oh, there we go. Okay.
Thank you. Hi, I'm here. Are you able to see my slides?
Yep.
Okay, great. Great. Well, good morning, everyone, and thank you for joining me. It's really great to see everyone on this call today. My name is Liz Couch, and I am here to share some insights on the critical role dental professionals and other health professionals play in tobacco cessation efforts. And our goal, I think, for this whole session is really to empower or help you as local oral health program officials and LLAs to effectively engage healthcare providers in your communities to support patients in quitting tobacco. I want to mention that I have no financial conflicts of interest related to tobacco, nicotine, or the pharmaceutical industries. I do work on several projects that receive research funding from entities such as the California Department of Public Health and the NIH. So just a brief overview of what I'd like to talk with you in my brief time today is one, the role of dental professionals in tobacco cessation, how dental professionals really compare to other healthcare providers in cessation efforts, provide some proven cessation strategies like the 5As and the AAR model, and tools and resources that can help healthcare providers support their patients in your communities, and how the entire dental team can contribute to that. And finally, just some collaborative opportunities that I think are available to help improve outcomes. And though the focus of my presentation is mainly on dental providers, I thought it's important to note that all of these strategies really apply broadly to other health professionals as well. So why should dental professionals get involved? Well, as you heard from Ben just now, tobacco use is a major contributor to oral health diseases such as gum disease and oral cancer, and it also decreases the success of dental treatment like implant placement and periodontal therapy. And beyond that, it severely impacts a patient's overall health, giving dental providers an opportunity to potentially save lives. And I'm not the only one who thinks thinks about this. The California Dental Association and the American Hygienists Association have affirmed that dentists and dental hygienists have a professional responsibility to educate patients about the risks of tobacco and to provide cessation support to their tobacco using patients. Likewise, this year, the World Health Organization put out clinical treatment guidelines for tobacco cessation in adults, and they recommend that all healthcare providers offer brief cessation advice to tobacco users in any healthcare setting. This is important because even brief interventions that last as little as 30 seconds can lead to meaningful outcomes. And there's a reason for such advocacy. Dental visits really do present regular opportunities to screen for tobacco use and provide advice to quit. Dental professionals are also very trusted health professionals and can often detect early signs of tobacco-related oral conditions. This makes them very well positioned to intervene. Research also shows that these interventions actually do work in dental settings. But despite that critical role that they play, many dental providers and care providers in general aren't really consistently engaging in tobacco cessation efforts. In fact, historically, dental providers engage in asking about tobacco use and advising patients to quit, but as you can see, fall behind other healthcare professions in providing tobacco cessation support and referring patients to additional support. And our team also found this to be true. In 2018, we surveyed dental professionals in California and found that many were asking about tobacco use and documenting it in the patient's chart, but fewer were advising or assessing a patient's readiness to quit, and even fewer were assisting or referring patients to outside resources. And I think this is a really interesting and important observation of the gaps that are available, that are present, that can, we can address and help to improve patient outcomes in the future. And there's a reason for these gaps. There are common barriers that you are going to hear and that you probably are all aware of and hear from dental health providers. I don't have enough time. It doesn't work. I don't get reimbursed. Patients might get upset with me. But research shows that these concerns, while fully understandable, are not insurmountable. For example, even a quick 3-minute discussion about tobacco cessation has been shown to significantly increase a patient's likelihood of making a quit attempt and being successful in that quit attempt. And despite this perceived fear of patient resistance, many tobacco users expect healthcare professionals to address their tobacco use, and they appreciate the support. And screening for tobacco use in dental offices has been shown to be positively associated with patient satisfaction. In fact, a majority of patients believe that dental providers actually should be providing tobacco cessation support in practice. And I think it's also important to note that a lack of reimbursement is in fact a barrier. But as we've seen in the chat today, in California and in New York, Medicaid now covers the dental code D1320 for tobacco cessation counseling, which I think helps not only address this sort of issue, but also sends a message to healthcare providers and to insurers that this is an important part of comprehensive oral health care. And now that we understand sort of why dental providers should get involved and some common barriers that we might hear in the field, let's look at some strategies that have been proven to help patients quit, and some key resources that you can share with dental providers and healthcare professionals in your community. So on the COHTAC website, you may all be aware of this, but you'll find a tobacco toolkit for California dental providers. This toolkit also includes a 1-hour webinar that introduces the concepts and strategies that dental providers can implement into practice. And as Aubrey may or may not be putting into the chat right now, COHTAC can actually provide data to local oral health programs on how many dental providers have taken this course and have utilized the continuing education opportunity for the webinar that they can use to report outcomes. So this is a really important resource, I think, for California providers. And so I want to go into a little bit more detail on what is included in this cessation toolkit. So let's talk about effective models within the toolkit that can encourage dental and health providers in your communities to adopt these changes. Two of the most proven models are the 5As model and the Ask, Advise, Refer model that Rachel alluded to earlier in her presentation. These are simple and adaptable, making them feasible for very busy clinicians. So the 5As model is meant to be adopted by the entire dental team and consists of asking about tobacco use, advising tobacco using patients to quit, assessing the patient's readiness or willingness to quit, assisting that patient in a quit attempt, and arranging follow-up. For patients who are not tobacco users, it's an opportunity to provide a message of prevention and congratulate that patient. And in the case where a patient has recently quit, it's an opportunity for dental providers or healthcare providers to assess any challenges that patient might have, to assess confidence, and to provide additional support to that patient. For those patients who are tobacco users but are not interested or willing to quit at this time, it's an opportunity for clinicians to provide brief motivational interviewing or motivational messages and set expectations, leaving the door open for future conversations. Similarly, this Ask, Advise, Refer model simplifies the process even further by focusing on asking about tobacco use, advising the patient to quit, and then referring them to external resources such as Kick It California or Tobacco Quit Line. These models are not just for dental professionals, they can be implemented by any health professional, from physicians to nurses to pharmacists. And if a dental team doesn't really feel equipped to provide full cessation support, they can still play a really pivotal role in making these referrals to outside resources. So let's look at these steps in a little bit more detail. So encouraging dental and health professionals to ask about tobacco use at all visits and document it in the patient's chart is really crucial. By doing so, they create a routine in which tobacco use is regularly addressed with all their patients starting at 12 years of age. This can easily be implemented into electronic health records, and some examples of this are, I take time to ask all of my patients about tobacco use because it's important. Or have you ever smoked or used other types of tobacco or nicotine products such as e-cigarettes? Clinicians should then advise tobacco using patients to quit and assess the readiness to quit. So a clinician's advice to quit is an important motivator for patients. So using non-judgmental language, they should deliver a message that is clear, that is strong, and that is personalized. When possible, dental providers, they also have this unique opportunity to link tobacco use to oral findings, which can be an important motivator for some patients. And when assessing readiness to quit, clinicians can simply ask, what are your thoughts about quitting? Or would you be willing to quit in the next 30 days? And what they will find is that most patients who use tobacco will not be ready to quit in the immediate future. So the goal for those providers should be to get the patient to really start thinking about quitting. And the way that we do this is through motivational interviewing. So you are all probably aware of it, but for patients who aren't ready to quit, motivational interviewing can be a really powerful tool. It's a patient-centered communication method, really designed to enhance a person's own motivation to change through partnership, autonomy, compassion, and evocation. So motivational core techniques include open-ended questions, they include affirmations, reflective listening, summarizing, all of which help patients to really explore their own reasons for making a quit attempt. And some examples of these core techniques are also found in the toolkit. Encouraging providers in your community to use motivational interviewing can help them feel more confident in addressing tobacco use, even with patients who might initially resist or not be as open to change. And there are excellent resources available in the toolkit, including webinars from organizations like the American Dental Hygienists Association, as well as one resource that Rachel mentioned earlier from the Smoking Cessation Leadership Center, which can really help educate healthcare providers on motivational interviewing techniques. So for patients who are ready to quit, the goal for providers really should be to help that patient achieve cessation, either by referring to outside support or assisting that patient in a quit attempt, or a combination of both. And I think it's important to point out that cessation works best when behavioral counseling is combined with FDA-approved medications like nicotine replacement therapies, bupropion, or varenicline. So the goal of brief counseling interactions is really to get patients started with their quit attempt. It really encompasses 5 things: helping set a quit date, usually within within the next 30 days, reviewing past quit attempts and treatment used by the patient, what worked, what didn't, discussing withdrawal symptoms and triggers that are most concerning to patients, and potential coping strategies. So using those motivational interviewing techniques to identify coping strategies that fit best with that patient and that patient's specific needs. Also referring that patient out for adjunct support or additional individual support, and recommending medications when appropriate. So there are 7 FDA-approved medications available on the market. In California, dentists are allowed to prescribe these medications to their tobacco-using patients. And if dentists aren't comfortable prescribing, they should at least be comfortable discussing options with patients and referring patients to other healthcare providers, such as their primary care providers or a pharmacist in their community to provide those prescriptions. And that last step in the 5 A's is arranging follow-up. This is key to successful cessation. So encourage professionals to follow up with patients at a week after their quit attempt and again within the first month. This can be done by any member of the healthcare team and does not require an in-person visit. So this can be done by telephone follow-up or text messaging follow-up as well. But for those providers who do not have time to provide assistance in practice, they can instead adopt this AAR model, where they ask the patient about their tobacco use, advise that patient to quit, and refer to outside support. And Rachel did such an excellent job of providing some referral resources, but I do want to reiterate what is available. So these options can include, but aren't limited to, individual face-to-face counseling. This can be with a healthcare professional with whom the dental provider, healthcare provider is familiar with. This can be a doctor, a nurse, a pharmacist, a therapist, or other tobacco treatment specialists within your community. There are also group or face-to-face counseling opportunities. And what I've highlighted here is this Kick It California County listing. And Rachel listed this, and I think Aubrey also included this in the chat. But I think this is a really fantastic opportunity for LLAs and LOHPs to really be collaborating on what this link is and what is included. So when we give these presentations to dental providers within California, we will often highlight this county listing. This is where you can find information about the referral resources available within your community. So I highly encourage you all, after you leave this session today, to go to this website, look at your county, and see what comes up. Is there a section on that website that includes information for healthcare professionals, referral resources for healthcare professionals? Because I think this is a real opportunity for more information targeted at dental providers as well as other healthcare professionals in your community that they can use to share with patients in practice. The other wonderful resource that I have to plug since I'm here is the UCSF Fontana Tobacco Treatment Center. This is a wonderful resource. They provide one-on-one counseling as well as group counseling, all remotely. So this is available to individuals throughout California, and it's a really fantastic resource and a great referral resource, especially for patients who are struggling with cessation, that have made multiple quit attempts and might need more intensive care. This is a wonderful resource for them as well. And of course, telephone counseling. Kick It California not only provides telephone counseling, but provides many other resources that Rachel so brilliantly pointed out earlier in this presentation. Additionally, there are great behavioral support options that help health professionals be aware that they should be aware of, that can be offered as sort of this adjunct to behavioral support, such as text messaging programs, smartphone applications, AI interventions, as well as internet-based interventions. And these tools are really easy to integrate into practices and help reinforce a patient's quit attempts. These are also really helpful, I think, for certain populations like youth who may not be as interested in certain cessation support like phone counseling. They may be more interested in text messaging programs or smartphone applications. So a key message for your community providers is that tobacco cessation isn't a one-person job. It takes a team effort. So in dental offices, this means everyone from the dentist to the dental hygienist to the front office staff play a critical role. The dentists can initiate the conversation about tobacco use and recommend medications. The hygienist can provide detailed counseling or motivational interviewing, and the front office staff can help schedule follow-ups and track progress using reminders in the electronic health record. The same principles apply across all healthcare settings. A physician might start the conversation, but a nurse or a health educator can assist with follow-up, and administrative staff can help sort of connect patients to resources. So engaging that entire dental team really ensures that patients receive consistent support at every step of the process. But for dental practices, I think it's important to point out that making sure, especially if they provide Medicaid dental services, that they're using this D1320. And even if they aren't Medicaid dental beneficiaries, I think it's really important to use this to really send a message to dental insurers that this is part of comprehensive oral care. And beyond individual providers, I think there's a role for you to create system level changes in your communities. So encourage dental practices and healthcare organizations to identify a tobacco cessation champion within their practice and implement standardized screening and intervention protocols. So this could include adding tobacco use questions to patient intake forms, creating prompts to electronic health records to remind providers to discuss cessation. One could also or should also implement tobacco-free policies in their dental settings and oral healthcare settings. And these steps can be adapted for all healthcare settings as well, making cessation efforts really more widespread. In the toolkit, we've also included some example workflows that really utilize the 5 A's and the AAR model that you can use to really develop your own screening and treatment protocols, or that dental providers can use to create their own screening and treatment protocols. We also have extensive list of cessation resources for patients, including phone counseling, text messaging programs, mobile applications, chat programs, and websites. And there are options for all audiences, including youth, veterans, adults, pregnant women, as well as others. So how do we get this information out to dental and healthcare providers in our communities? Well, you are all the public health experts, so you know what's going to work best in your communities. You're all doing this work right now and have been doing this for several years. So I think it's really lovely that you're all working together and collaborating. There are a few things that, in my opinion, can help. One is that local oral health programs can really partner with LLAs to offer dental practices, training, resources, and support for tobacco cessation, developing workshops or sharing continuing education opportunities tailored to dental providers on tobacco cessation, like the COHTAC toolkit and the webinar that is a free CE for dental providers in your community, and providing referral resources and cessation aids through local dental practices. So sharing the referral options that are available in your community so that they're clear to dental providers and that those dental providers can then share them with patients. And really engaging professional associations and components. So making sure that you're communicating with the California Dental Hygienists Association, the California Dental Association, as well as dental assistants, and making sure we're engaging them and tapping into that resource in order to share crucial information with dental providers. So to leave you, here are some takeaways. Dental and healthcare professionals can make a significant difference by addressing tobacco use in practice. Simple strategies like the AAR, the 5 A's, motivational interviewing can be easily integrated into daily practice and can really make a significant impact. And it takes a team effort to achieve results with every healthcare professional and every community partner really playing a pivotal role. So by encouraging these strategies, you can help dental and healthcare professionals in your communities provide much needed support for patients looking to quit tobacco. And with that, I will turn it back over to Aubrey.
Amazing. Thank you, Liz. This has been a lot of information, and so I'd like to pause now for questions, and I'm going to invite Kristen Hoft, the director of COHTAC, to facilitate.
Thank you so much to the speakers. You did an amazing job. We're so glad to have you share your time with us. And I also want to thank all the attendees for your active engagement and putting all those questions in the chat. Seems like many people have been providing answers as we go in the chat. And I want to assure you that all the information from the chat will be included in the resources from this webinar. And let's get into some of the questions that we haven't fully answered yet. So the first one is to share some more specific information about the CE. So I want the free CE opportunity for dental providers. So I want to invite Aubrey to just give a little bit more information to you all about how that works and how you can get additional information about who from your county is taking it.
Yeah, happy to. So we at COHTAC are the C provider. We are the ones who are issuing the certificates to providers who take that course. And so we know exactly who did it, when they did it. And so if you reach out to us at oralhealthsupport@ucsf.edu, I'm happy to do a download and report out back to you who took the course. And I think really the more specific, detailed information about how you do this is really about getting the word out. So here's a great starting place where we're telling you that this is available, but it's you and your connection, your network with dental providers in your area to share this opportunity with them.
Thank you. All right, we have another question about for youth parents. Do dental providers need a consent from parents or guardians to provide sedation counseling, especially if the parents or guardians are not aware of their child's tobacco use? Can I invite someone to jump in with that answer?
So yeah, it's a great question. In California, dental providers are allowed to have conversations with youth who are over the age of 12, both with their parents or without. So it is up to the discretion of the dental provider or the healthcare provider on whether they are going to integrate parents into that conversation. But they're encouraged, we always encourage the dental providers that we communicate with to try to engage parents in this conversation, because a lot of times parents can be aware of this, but having those conversations with youth can happen with or without parents. And sometimes I think it's really important for dental providers to realize that when they're having these conversations, sometimes it can be really helpful not to have a parent in the room when they're asking about tobacco use, because you'll often get a more truthful, a potentially truthful response from youth on their actual behaviors if parents aren't actually in the room. I do believe that in order, and Rachel, you might be able to correct me if I'm wrong, but for the web-based referral, I do believe that a parent needs to consent in order to send that electronic referral. But in the state of California, dental providers are allowed to have those conversations with their youth patients.
Thanks, Liz. I am actually going to see if by chance, I know she's on, but I don't know if she has the capability to respond. Anna from Kick It, are you able to comment on anything specific when it comes to consent or the referral process specifically when it comes to youth? I just see that you're on, so I'm not sure if you can best speak to it. If not, I'll also just note, I'm not sure in terms of the medical aspect, in terms of the web-based referrals for EHR that you're referring to, Liz, but I know in terms of if an individual, regardless of their age, goes to the Kick It California website to do that self-referral process, it does not need an adult to be there in order to submit the referral. So I'm talking about the web-based when you go to Kick It California's website, not necessarily in the dentist clinic themselves. So I'll make sure to follow up with Aubrey and her team about that to make sure that that's answered more clearly.
Great. Rachel, do you mind answering the next question that was put into the chat, which is a request on where people find information that people can share with younger parents? I mean, younger patients. You mentioned that Kick It CA was for like more teen years. Do you have any recommendations and suggestions for that?
Um, I'm trying to make sure that I'm seeing the comment correctly. So, I mean, so every Kick It service that I mentioned, for the most part, except for maybe things like the eligibility in regards to NRT patches or things like that, that's all available to 13 plus. in terms of individuals that are using Kick It services. So those are all available, as well as when I linked the service flyer for cessation resources that the CTPP team and I created, that all lists specific youth resources that are cessation focused both nationally and in the state of California. So that's something that you all are able to provide and download and give to dental health professionals when encouraging those conversations with youth regarding any individual that might be younger than 13. I'm not sure. There's I think Ben mentioned in some of his presentation and Liz as well, a lot of research and services are really geared towards older populations. So I know that's somewhere where we're still trying to actively work for when it comes to that. But those that I mentioned in my presentation are all offered in terms of the 13 plus years. So hopefully that can target and help serve some individuals in that category.
Thank you. I'm gonna bring it back to Aubrey to do a close, and then if people still have remaining questions and want to stay on after that, we can do our best at least to collect the questions and get answers as part of the resources for this meeting.
Yeah, thanks, Kristen. So I'm acknowledging we are at time, so I'm just going to launch our evaluation poll, and you can read through that while I'm doing a little bit of wrap up. So that should pop up on your screen now. And I also want to highlight that at the very end there, if you want COHTAC or CTPP to help facilitate connections with your local counterparts, if you're from an LOHP or an LLA, we are happy to do that. So I'll keep that up for now as I run through some of my wrap up slides. Some of you on the LOHP side may be really interested in this. So the bill that adds TK to COA, the Kindergarten Oral Health Assessment, was signed by Governor Newsom and will go into effect in January of 2025. And we know you're looking for more information about that, and I promise we are working hard to figure that out. So stay tuned on that. I also want to share that we have an upcoming information session for any LOHP who is interested in hosting a dental public health resident. Please join us on Thursday, November 7th from 11 a.m. to 12 p.m. We'll send this out as a link also in the follow-up email. But just want to let you know that this was rescheduled from October to November. And then the last COHTAC webinar of the year will be on November 21st. We'll be sending this out to you shortly. It's focusing on care coordination. So we will talk a lot more in depth about how LOHPs are coordinating care at that webinar. And that's it. So I just want to thank each one of you for being here today. We're so excited to have invited the LLAs to join the LOHPs in this webinar. Huge kudos and thanks to Rachel, Ben, and Liz for presenting today and sharing their wealth of knowledge and resources. And I hope you all have a wonderful rest of your day. Thanks for being here. Take care.